All right. So we'll back up the process here. Pre-intervention. So how do we know that we truly have severe aortic stenosis worthy of an intervention? So the prime directive, right? The flow rate is directly proportional to the pressure gradient and inversely proportional to the vascular resistance. Okay, that's all the real physics I'm going to show you. But we forget about resistance. So one of the things that you need to consider is the appearance that the AS got better. All right, so we see them, we have a certain velocity. 6 months later, we see them, and the valve area is bigger, the gradient's lower. It's like, wow, that's good news. It's never the case that the valve got better. It's either you missed the Doppler velocity or the blood pressure's higher. So those are the things. So high blood pressure 170 one day, it was 130 6 months ago. That will actually change your valve area calculation. So remember to record, that's my little public service announcement, record the blood pressure, think the blood pressure, and recognize that the resistance is actually part of what determines pressure gradient across the aortic valve. Okay, so we know this. We've all got the Bernoulli equation tattooed somewhere. We don't need to memorize any of that. What we remember is the simple version, delta P is 4V squared. So that's all we ever use in defining severe aortic valve stenosis. So real simply, this is the flow across the valve. This is an example of a continuous wave Doppler. And what we teach our fellows is if it's 2 or less, it's normal. If it's over 4, it's severe. And we really only need to think about it when the peak velocity is somewhere between 2 and 4 meters. That's when we have to actually do some cognitive effort. So why do we talk about mean gradient so much, right? We can do a peak gradient by catheter. We used to do that all the time. We can still describe peak gradients by echo, but we generally prefer to talk mean gradients. Why do we talk mean gradients? We talk mean gradients because the correlation between a catheter mean gradient and a Doppler-derived mean gradient is actually excellent. So there isn't that discrepancy between cath and echo when you talk mean gradients. The other thing is if this CW shows, when you do a mean gradient, you're tracing a contour, and all of us in this room could probably trace the same contour, be within 10%. If I said, show me the peak, we might have a very different appreciation of where that peak is. So inter-observer variability is much greater when you talk peak gradient, much more reproducible when you talk mean gradient. So that's why we talk mean gradients whenever possible. This is an example of an easy one. So thickened calcific valve, preserved EF, one of the first patients I ever saw with a velocity over 6 meters and a mean gradient of 100 millimeters mercury. Amazingly asymptomatic. I bet the strain wasn't normal. This is before we did strain. But occasionally symptoms aren't our guide. This is a concern, a 6-meter jet. So 100 millimeter mean gradient, peak is much higher. So we have guidelines, of course, and I just wanted to focus on one thing. So the severe guidelines are fairly universal generally. Velocity over 4 meters, a mean over 40, and a valve area less than 1. These velocity and gradient depend on flow. So that's an important message. This assumes normal flow. We'll come back to that concept. The valve area of 1.0. Those in this game for a while, we recall, we used to say 0.8. And suddenly, almost miraculously, it became 1. Why did it become 1? And we'll talk about that. One thing to remember, though, and this is another sort of public service announcement, is the different Doppler angles, and critically important. So this is a patient 1 at the top. The apical peak velocity is 5 meters. The right peristernal 4.7, fairly reproducible. A different patient, the apical was 3.7. The right peristernal was 5.1. So 5.1 is a lot higher than 3.7. So this was a nice Mayo study that looked at a whole lot of patients. And they, of course, did the blind imaging, pencil probe between the ribs, right peristernal and suprasternal notch in every patient. And they had over 50% of the patients, the highest velocity recorded was actually from the right peristernal. So in an AS evaluation, it's critical to be evaluating from that view. Because the Doppler angle, you don't quite know how the heart is lying. It's easy, relatively easy, to miss the axial velocity of the flow. So right peristernal is a super important view to be acquiring in these patients. So back to the gradient. This is a study from a while ago, but it looked at a lot of patients where you plot calculated valve area versus mean gradient, and you see the densest cluster for a mean gradient of 40 is a valve area of about 0.8. So you could use 0.8. That would be more specific for severe aortic stenosis, but the goal in these cases is really to be more sensitive. So if you want to make sure you don't miss anybody with aortic stenosis, that's why the valve area moved from 0.8 to 1.0. More often than not, if you've got a mean gradient of 40 in somebody with normal flow, their valve area will be closer to 0.8. but that's why the guidelines say 1.0 to be most sensitive for the determination of severe AS. So how do we get to valve area? Okay, flow on one side of the valve has to equal flow on the other side of the valve. That's the continuity equation. Stroke volume equals stroke volume. Break down stroke volume to area times velocity, and then you solve for area. That's basically how we get to a valve area calculation. The components, of course, we need the LVOT diameter to get cross-sectional area. We need distance blood traveled, or the VTI in the LVOT, and we need the velocity and distance blood traveled from the CW. And there's the math on cross-sectional area. From the guidelines, important to recognize that we do the LVOT determination from trailing edge to leading edge. So from the sonographers, this is a straight out of the guidelines. We want to make sure we get that measurement right. Otherwise, whatever we do, we square it. So if you're wrong, you square your error, which is one of the challenges with the aortic valve area calculation. But the other important message is to know where you put the sample volume. So generally between 0.5 and 1 centimeter proximal to the aortic valve, your goal is to get flow before it accelerates into the valve. And this is an example of actually somebody post TAVI, but just demonstrating different locations where you put the LVOT pulse wave Doppler and how you can get very different stroke volume determinations. So you want to be capturing a velocity. Roughly, we usually start around 0.5, move up a little bit into the LV if you have to, but you want to get the pre-accelerated flow of the LVOT. One of the most important things to know when you've got a good pulse wave is what's the quality of the flow. And this is 3 different patients, 3 different samples, and we refer to these as the roller, the spray, and the pencil. So how did you get them? And you always want to achieve the laminar flow of the pencil. Again, we had an excellent lecture earlier about laminar flow across the aortic valve. Laminar flow looks like your pulse wave Doppler is drawn by a pencil. So we're seeking pencils all the time. And again, inter-observer variability very low. You're tracing a pencil, we're all going to trace the same line. You get a roller, it's harder to be confident about that laminar flow. Okay. So pitfalls of the continuity equation are shown here. The error is squared in the LVOT determination. Lots of challenges with the LVOT velocity and the Doppler angle. Continuous wave Doppler, right peristernal, super important, suprasternal notch. And move in now to the patterns of aortic stenosis. This is where, again, some of the mental effort, velocities between 2 and 4. What's going on there? The one on the left is the easy one. This is the normal EF, high flow, high gradient. This is the AS we all want to come across. Easy, we all agree this is severe AS, high flow. The paradoxical low flow, low gradient, the paradox here is that the flow is low, but the EF is normal. So that's what the term paradox means. So this is basically the small concentric hypertrophy LV. EF is fine, generally small older people, but this is paradoxic in that the quantitation of the flow is less than 35 milliliters per meter squared. That's our sort of cutoff for low flow. But that's the phenotype, which is a little more challenging. And then the one that we sort of all recognize, but we still have to do a bit of cognitive effort on, is the low flow, low gradient. So generally, this is the big baggy LV. So the forward stroke volume is diminished, the gradient is low, valve area calculation may still be below that 1.0 or 0.8. This is a little more work to know, is the gradient low because the AS is not severe, or is the gradient low because I'm not putting much flow across the valve? That's where we have to figure things out. You can think about that concept as this 2x2 table. Every patient, think normal flow or low flow, high gradient or low gradient. And this is sort of the concept that we use to sort of go through this determination of how severe is the AS. And I see some photos happening. These slides are all freely available, PDF, whatever. They're all yours anyway. So you don't have to take photos. You'll get all these. But in this low flow concept, that's where we can spend a minute thinking. So this is the EF normal or is the EF depressed? That's generally how we approach low flow. And I'll take you through some cases to sort of highlight some of these concepts. So first case is a 75-year-old male with aortic stenosis and symptoms. So you can see is to get a depressed EF. The baseline values give a stroke volume of 40 mils, mean gradient of 46, and a valve area of 0.4. So the mean gradient's 40, already meets qualifications for severe. Valve area is less than 0.8, already meets severe. These are the numbers. So this is pretty easy. This is low flow, normal gradient, severe AS. Just because the EF's down doesn't mean you ignore all the numbers. The numbers still meet it. So this is the worst AS. Even with a terrible ventricle, he still meets all the criteria for severe AS. So this is a very sick patient. So that's normal flow, low flow, normal gradient, sick patient. This is a different one. This is somebody depressed EF again. Stroke volume is 44, peak velocity 2.7, mean gradient is only 16, and the calculated valve area from the math I've shown you here is 0.94. Okay, so there is AS, but how severe is it? How do we resolve this? Is this low flow, low gradient? What is this? This is the scenario where dobutamine is very helpful. The idea is, can we get this ventricle to squeeze a little harder, increase the flow, and see what happens to the valve area calculation? So on the top left is baseline. Jump down to the bottom right. You can see there's an augmentation of systolic function, more than 20-25%. And the difference in the math is post augmentation with dobutamine. Now we have a stroke volume goes up to 65. The velocity only goes up to 3. And because we had an LVOT increase that was greater than the CW increase, now the valve area calculates at 1.4. So this is not severe aortic stenosis. This is a sick ventricle with a little bit of AS, but not severe AS. So this is low flow, low gradient, non-severe AS. So the dobutamine in this case was very helpful. Another case is this one severe AS. Depressed EF, pretty typical calcific aortic valve. At rest, we have a peak velocity of 2.7, stroke volume 45, valve area calculates at 0.7. Okay. Give our dobutamine, what happens? The velocity goes up to 4.1, mean gradient goes to 40, valve area stays pretty close to the same at about 0.8. So here we've revealed, even when we augment flow, EF gets a little better, but the valve doesn't open anymore. So that is low flow, low gradient, severe aortic stenosis. And what we're seeing increasingly is this scenario. 83-year-old woman had a remote cab, now with dyspnea. This is her mitral valve. This is her mitral valve CW. This is a very tall E wave on the mitral valve, over 180. So that's either restrictive diastolic features, or that's a lot of MR trying to get back in. So this is one of the features of severe MR. And she's got an aortic valve that looks like this. And a CW about 3 meters. I know, what is this? She's got bidirectional. She's got MR and she's got some AS. And how do we sort of resolve this lost flow? So it's low flow because a bunch of the ejected blood is going backwards, not going across the aortic valve, not contributing to the gradient and the velocity that would help us determine the AS severity. Well, this is the scenario where now, these days, what we do is we turn to CT. Because you can't give dobutamine to somebody with severe MR, you're just going to make the MR worse. The thinking here is this is where we do a valve calcium score by CT. In a woman, if the valve calcium score is over 1,200, we're pretty confident this is severe AS. Valve calcium score is 500, probably not. And this is where calcium score becomes quite helpful. So AS can be underestimated. When there's MR, it gets worse. And if you combine MR and LV dysfunction, it gets pretty tough. This is one of my favorites. 91-year-old gentleman in a remote cab, now with dyspnea, and the 3D tells it all. The mitral valve doesn't close, and the aortic valve doesn't open. So he has significant AS and significant MR. You know that from the 2D images. The only dilemma here is which one do you treat first? So this has an aside. Mitral intervention is very difficult in the setting of severe AS. So this would be TAVR first, reevaluate, almost certain that MR is not going to go away completely. TAVR, then reevaluate mitral and possibly edge-to-edge repair. Generally, that's how we'd approach it. And this is, I think, my final case and one of my favorites because it sort of predates TAVR by a little bit and shows you some of these Doppler principles of AS. This was a woman we encountered a year before we began our TAVR program, and that's important. So she is in her 60s, large pleural effusion, a better with thoracentesis. She had a very large abdominal lymphoma, non-Hodgkin's. She started chemotherapy. Somebody heard the murmur. He comes to valve clinic, did not want to interrupt her chemotherapy. So this is in February of 2010. She's got concentric hypertrophy, a normal EF, calcific aortic valve. This is her velocity, over 6 meters. So asymptomatic, sort of, with an abdominal lymphoma. Valve area 0.4, 100 millimeter mean grade. We're not going to wait. We're going to treat this as soon as we can, but she's undergoing chemotherapy. Surgeons are very concerned about. Oncologists don't want to interrupt the chemotherapy to do an AVR. What do we do? She had no symptoms whatsoever, despite a 6 meter jet. We would have wanted to treat her. She says, no way. Options, do nothing. She's asymptomatic, interrupt for chemo, finish the chemo, valvuloplasty. Her answer was nothing right now. I want to finish chemo. I'll show you this slide. Why do we get excited by a 6 meter jet? It's because we're excited by a 5 meter jet. The basic teaching is if your jet is 5 meters, that's a symptom. You're no longer asymptomatic because at 5 meters, you actually have a mortality compromise by not doing therapy. So we will have discussions around asymptomatic state up to 5 meters. Less and less so, frankly, because TAVI is becoming less and less risk and surgical risk is going down. But historically, we would discuss presence or absence of symptoms to 5 meters. But over 5 meters, you intervene, basically. So she's well beyond this. We want to intervene on an aortic valve. She wanted to keep going with chemo. She completed the chemo. She developed refractory thrombocytopenia, not surprising with chemo. No dyspnea, strongly advised to undergo AVR. She refused. A couple of weeks later, we get a call from a community hospital. She's there. She's intubated. This is her echo then. Her EF is clearly fallen. Her valve mean gradient now is 113. Velocities are well over 6, despite an EF reduction. So sick ventricle gradients are still enormous. Valve area calculated at 0.3. Now can't get her off a ventilator. Now we do a balloon valvuloplasty, TAVI, 100 millimeter gradient goes to 50 millimeters. So a 50% reduction in the mean gradient from a balloon, not a durable therapy. You don't expect that to last months or years, but short term, get her off a vent. It worked. Still has severe AS with a mean gradient of 50, but that was a nice response. She recovered. Then finally was doing well, no dyspnea, still has thrombocytopenia. At that point, we all bit the bullet. She did 2 surgical AVR, complete recovery of EF, but it's a nice Doppler procession about what happened in her story. We don't sort of get these semi-natural histories anymore. So pre-balloon, aortic valve balloon, 6 meter gradient, 100 millimeter gradient to 50 millimeters gradient, and after a bioprosthetic AVR, a 21 millimeter gradient. And what did the EF do during all that time? Went from normal to almost hyperdynamic. Sorry, there's the numbers. EF 65, EF 40 before balloon valvuloplasty, and then EF basically returned to normal. Valve area went from 0.4 to 0.3 to 1 after a bioprosthetic AVR. So it's an amazing story about how the EF responds and how the gradients changes and how valve area matters, and we just don't get to do these stories anymore with TAVR. So Doppler hemodynamics, you've got to know the principles, which we try to show you briefly, know the limitations and some of the pitfalls, particularly of the continuity equation. The Doppler pressure is calculated, so there are definitely assumptions, and it never gets better without an intervention. And recall the prime directive that resistance matters and blood pressure matters in your serial evaluations of aortic stenosis. And I'll stop there. Thank you very much.